Welcome to the Deep Dive. Today, we're doing something a bit different. We're not just listing disorders. We're really exploring the, well, surprising ways our brains can sometimes trip us up.
Absolutely. We're looking at everything from losing control of an impulse to, subtle shifts in how we think.
To the mysteries of sleep and that whole complex world of substance use.
Exactly.
We've got a really fascinating collection of sources today. And our mission for you is to cut through all the noise, maybe reveal some hidden threads connecting these things that seem, well, pretty disparate.
And highlight the most important nuggets of knowledge from these diverse fields. What's truly compelling here, I think, is how these conditions, though they seem distinct, they often share common threads, maybe unexpected risk factors, or even sometimes overlapping treatment strategies.
Okay.
So we'll try and connect those dots for you, give you a clear, sort of comprehensive picture.
Great. So let's jump right in then. We're starting with impulse control disorders. And like you said, these aren't just, bad behaviors, right?
Yeah. Not at all. They're genuinely complex disorders. They have specific criteria, fascinating underlying factors.
We'll unpack oppositional defiant disorder, conduct disorder, and intermittent explosive disorder. So first up, ODD, oppositional defiant disorder.
Right.
Our sources describe this pattern of defiant, angry, spiteful, argumentative behavior. And it has to persist for, at least 6 months?
That's right, 6 months plus. And it really impacts a person's life, school, friendships, family life. It's quite pervasive.
What's really insightful, I thought, is that individuals with ODNE often don't seem to respond to traditional punishment.
That's a key point. It seems they're driven more by this strong desire to seek large rewards.
Which radically shifts how you might think about interventions, doesn't it?
Completely. And the DSM-5, the Diagnostic and Statistical Manual, requires 4 or more symptoms. These fall into categories like angry or irritable mood, defiance, or vindictiveness over that 6-month period.
And it usually shows up fairly early.
Typically around age 8, yeah. Interestingly, while boys are more frequently diagnosed, girls tend to show more of the argumentative behavior specifically.
And comorbidities are common,
Yeah.
things occurring alongside it.
Very common. About 40% also have ADHD, attention deficit hyperactivity disorder, and it can overlap with anxiety, depression, even DMDD, disruptive mood dysregulation disorder.
Which is that severe irritability and anger.
Exactly. So it gets complex.
When we look at the roots, the causes of ODD,
Yeah.
our sources point to both kind of nature and nurture playing a role.
They do, yeah. Genetics are significant. It's about 40-60% heritable, which is quite high.
Wow.
Neurobiologically, we sometimes see less gray matter in certain brain areas, maybe reduced brain activity.
Yeah.
And then environmentally.
Like environment.
Things like ACEs, those adverse childhood experiences, trauma, abuse, neglect. Also, poor parenting, abuse itself, large family sizes, lots of family conflict. Those are all identified risk factors.
Okay, that gives us a strong foundation for ODD.
Yeah.
Now, moving from that kind of defiance to something that sounds, more outwardly damaging maybe. Conduct disorder, CD. This involves a pattern of behavior that consistently violates the rights of others, societal rules,
Yeah.
often with aggressive action.
Yes.
The motivation here sounds really different from ODD. What are we looking at exactly?
You're absolutely right. The motivations seem to diverge quite a bit. With CD, individuals often crave excitement. There's often little concern for consequences.
Right.
The DSM-5 emphasizes that persistent pattern of behavior infringing on rights, breaking rules, aggression being a key component.
And it can start at different ages.
Yes. There's a childhood onset, so before age 10, and an adolescent onset after 10. Childhood onset is actually more common in boys.
Okay.
But adolescent onset is roughly equal between genders. And again, comorbidities are frequent ADHD, major depression, bipolar disorder, substance use disorders, learning disorders too.
And the risk factors.
Yes.
Similar mix.
Similar mix, yeah. Inherited predispositions plus learned behaviors. Neurobiologically, again, maybe less gray matter, other brain changes, and a notable lack of empathy often.
Lack of empathy, that's significant.
It is. And environmentally, again, ACEs, family violence, maltreatment, abuse, those are significant contributors.
Okay. Our third one in this group, intermittent explosive disorder, IED. This sounds different again. It's characterized by sudden, unprovoked aggression, verbal or physical.
Yeah, sudden outbursts.
So it's not planned. It's just this sudden explosion of rage that feels very different from the more deliberate stuff maybe in CD.
It truly is, yeah. The lack of premeditation is key. For an IED diagnosis, the DSM-5 requires these recurrent aggressive outbursts that are well, grossly out of proportion to whatever triggered them, if anything.
Right. Completely over the top.
Exactly. Not planned, they cause significant distress, and they aren't better explained by some other disorder. It often starts in childhood, most common in people under 50, and more prevalent in males.
And comorbidities again.
Oh, yes. Major depressive disorder, anxiety, substance use disorders, ADHD, ODD, CD, even antisocial or borderline personality disorders can co-occur.
And the brain seems to play a really specific role here, almost pinpointed, doesn't it, based on the sources?
Absolutely. Neurobiologically, there's often evidence of reduced serotonin, that key neurotransmitter, and maybe even neuron loss in the amygdala and hippocampus.
Wow, key areas for emotion and memory.
Critical areas. Physiologically, sometimes elevated C-reactive protein, which is a marker of inflammation, and IL-6, another inflammatory marker. Testosterone levels might also be associated.
Interesting.
And environmentally, again, family violence, maltreatment, abuse are noted risk factors. This all raises, an important question.
Yeah.
How do these sort of subtle neurobiological and physiological differences contribute to such distinct behaviors, especially that sudden, unprovoked nature of IED? And why is that important for us to grasp?
Right. It really shifts the focus for treatment, doesn't it? Towards understanding triggers, maybe neurological regulation.
Precisely. It's not just about managing behavior, but understanding the underlying mechanisms.
And speaking of treatment, for all these impulse control disorders, our sources highlight quite a range of approaches.
A whole toolkit.
We're looking at therapies like CBT, cognitive behavioral therapy helps people change thinking patterns.
Right.
DBT, dialectical behavior therapy, focusing on emotional regulation, parent-child interaction therapy, PMT, parent management training, MST, multisystemic therapy. It's a lot of acronyms.
It is. And they target different aspects, different systems, the individual, the family.
And then there are medications. Things like SSRIs, the antidepressants, divalproic sodium, a mood stabilizer, other mood stabilizers too.
Yeah, and these are often tailored very specifically to the disorder, and crucially, any co-occurring conditions, those comorbidities we mentioned.
Makes sense. Okay, so we've explored how impulses can kind of go off the rails, but what about when the very framework of our thoughts, memory, judgment starts to shift?
Yeah, a different realm entirely.
Our sources show it's not just one single path. It's more like a landscape of cognitive change, marked by conditions like delirium, dementia, and Alzheimer's. What's the sort of key distinction for delirium?
Well, what becomes strikingly clear here is that while all three affect cognition, understanding their onset is often the first, most critical clue for clinicians.
Okay, the speed.
Exactly. Delirium is an acute disturbance. It fluctuates, it affects attention, cognition, and the onset is sudden, usually hours to days.
That fast. Wow.
Yeah. Risk factors are varied, could be existing cognitive issues, infections, certain medications, dehydration, sleep deprivation, even sensory problems like poor hearing or vision.
And the signs, what does it look like?
Acute confusion, awareness that fluctuates. They might be alert one moment, drowsy the next, altered responses to their environment, sometimes even hallucinations or delusions.
So it's this really sharp, sudden change in mental status.
Yeah.
How do you manage that, given how acute it is?
The number one priority is always to treat the underlying cause. Find out what triggered it. Antipsychotics might be used carefully if needed for severe agitation or psychosis, and safety measures are absolutely crucial.
Like what kind of measures?
Well, for nursing interventions, things like bed or chair alarms to prevent falls, non-skid socks, making sure they're hydrated, helping with toileting regularly, maybe limiting complex decision-making for the patient.
Keep things simple.
Keep things simple, maintain a consistent, predictable routine. That all helps stabilize them while you treat the root cause.
Okay. Now, building on that idea of cognitive changes, but shifting from that acute confusion to something more chronic, progressive, that brings us to dementia.
Right. Unlike delirium, this is usually a much more gradual process.
Yeah, that's the key difference.
It's a major one. Dementia is defined as a chronic, progressive decline in cognitive function. Its onset is gradual, typically taking months to years to really develop.
And the risk factors.
Key ones include age, that's the biggest one, family history, cardiovascular disease, diabetes, history of head injury.
And the signs and symptoms. What do we typically see?
Memory loss is classic, of course, but also confusion, poor judgment, impaired language abilities, problems with executive function, planning, organizing, that sort of thing.
And treatment for dementia?
It's largely supportive care. Managing any other medical conditions they have, maybe using antipsychotics if behavioral issues like aggression become really problematic, but there's no cure, sadly.
So the focus is on quality of life, support.
Exactly. Nursing interventions focus heavily on emotional support, trying to maintain consistent caregivers in a stable environment, managing anxiety, reducing overstimulation, and carefully monitoring nutrition and hydration, which can become issues.
Got it. And then within dementia, there's the most well-known type, Alzheimer's disease. How does this differ from that broader category of dementia? What are its unique hallmarks?
Alzheimer's is a specific progressive neurodegenerative disease. It is the most common type of dementia. Its onset is also gradual, with symptoms worsening over time, sometimes slowly, sometimes more rapidly.
Risk factors similar to general dementia.
Largely, yes, age, genetics, cardiovascular health, traumatic brain injury. Lifestyle factors also seem to play a role, like low physical activity or poor diet.
And the symptoms, are they more specific?
They can be, yes. Profound memory loss, of course, but also things like aphasia, that's difficulty with language.
Right.
Apraxia, difficulty with motor skills like using utensils. Agnosia, difficulty recognizing familiar objects or people. We also see sundowning, where confusion and agitation worsen in the late afternoon or evening. Confabulation, where people invent memories to fill in gaps. And sometimes hyperorality, putting things in their mouth.
Those are quite distinct symptoms. Are there specific medications for Alzheimer's?
There are. Cholinesterase inhibitors, like donepezil, are often used for mild to moderate stages. They help with neurotransmitter levels. Then there are NMDA receptor antagonists, like memantine, for moderate to severe stages.
Okay.
Antidepressants, antipsychotics, anticonvulsants might also be used to manage specific symptoms like depression, agitation, or seizures.
And nursing care is intensive.
Very much so. Extensive support with ADLs, activities of daily living, comprehensive caregiver education and support because it's incredibly demanding. Lots of safety measures, and establishing a structured, predictable routine is vital.
So the key takeaway, as you mentioned earlier, is really distinguishing these conditions based on onset sudden for delirium versus gradual for dementia and Alzheimer's.
Exactly. And looking at those specific symptom profiles, it's absolutely critical for getting the right diagnosis and planning appropriate care. You treat delirium very differently than you support someone with Alzheimer's.
Makes perfect sense. Okay, let's shift gears now. Let's dive deep into the world of sleep.
Sleep. So important.
So important and far more complex than just, getting enough Z's. It's really a critical pillar of our overall well-being. And when it's disrupted, wow, it can manifest in some really surprising ways.
It really can. So we can start with maybe the most common one, insomnia disorder.
Right, trouble sleeping.
Basically, yeah, dissatisfaction with sleep quantity or quality. Specifically, difficulty falling asleep, staying asleep, or maybe waking up too early.
And how is that treated?
CBTI, cognitive behavioral therapy for insomnia, is actually considered the first-line treatment now. It's very effective.
Okay, therapy first.
Therapy first. Plus, improving sleep hygiene, consistent schedules, cool, dark room, you know the drill. Medications can be used too, of course. Benzodiazepines, non-benzodiazepine hypnotics, melatonin receptor agonists, even certain antidepressants. The goal is really to improve sleep onset, sleep maintenance, regulate those transitions.
Okay. Then there's the flip side almost.
Yeah.
Hypersomnolence disorder. Excessive daytime sleepiness. Sounds like a constant struggle just to stay awake.
It really can be. For hypersomnolence, supporting healthy sleep habits is still key. And it's really important to rule out other medical conditions or sleep disorders that might be causing it.
Like narcolepsy.
Exactly. If narcolepsy is diagnosed, then stimulants might be used to help promote alertness during the day. Narcolepsy itself is more complex than just sleepiness, though.
Right, it has those other features.
Often sudden sleep attacks, cataplexy, that sudden loss of muscle tone, often triggered by strong emotions.
It must be scary.
It can be very disconcerting. Also, sleep paralysis and hypnagogic hallucinations, those vivid, dreamlike experiences right as you're falling asleep.
And treatments for narcolepsy.
Medications like modafinil, sometimes amphetamines or phenidates, and some newer non-stimulant options are used. They aim to stimulate wakefulness and reduce those sleep attacks and cataplexy.
Okay. What about breathing-related sleep disorders? Things like snoring, apnea. They sound like they have really profound physical effects.
They absolutely do. These involve things like loud snoring, but more seriously, episodes where breathing actually stops apnea or becomes very shallow, leading to nighttime desaturation where oxygen levels drop.
And the treatment there is usually those machines.
Right. CPAP, continuous positive airway pressure, or sometimes BiPAP, bi-level positive airway pressure devices are the mainstays. They work by keeping the airway open during sleep.
Then we have circadian rhythm sleep disorders. This is when your internal clock is just off, right?
Exactly. Your sleep timing is misaligned with the external schedule. Think shift work or chronic jet lag.
How do you fix that?
It's addressed with, again, really consistent sleep hygiene. Light therapy can be very helpful, using bright light at specific times to help reset the body clock, and behavioral support to help align that internal rhythm with the environment.
What about those more dramatic sleep events, like sleepwalking or night terrors?
Right, those fall under non-REM sleep arousal disorders. They include sleepwalking, sleep terrors. Usually the person has amnesia for the episode afterwards.
Boy, they don't remember it.
Typically not. Short-term benzodiazepines might occasionally be used if they're very frequent or dangerous, but mostly it's about ensuring safety, locking doors, removing obstacles, and improving overall sleep hygiene.
And nightmare disorder, that's different from night terrors.
Yes, different. Nightmare disorder involves really frightening dreams that cause the person to wake up scared. They usually happen later in the sleep cycle, during REM sleep, and the person remembers the dream vividly.
Treatment for that.
Often counseling, good sleep hygiene, maybe reducing stimulation before bed, scary movies, stressful activities.
Okay. And REM sleep behavior disorder. I've heard that one can be quite unsettling.
It is, yeah, because it involves literally acting out dreams during REM sleep. Normally, our muscles are paralyzed during REM, but in this disorder, that paralysis doesn't happen properly.
So people might thrash around, punch, kick?
Exactly. It can lead to injuries to themselves or a bed partner. What's particularly interesting and concerning is its link to neurodegenerative diseases like Parkinson's.
Really?
Yes, it can sometimes be an early sign, and it can even be worsened by some common medications like SSRIs and SNRIs.
Wow, so the focus is safety?
Primarily safety measures, yes, preventing injury. And ruling out those underlying neurodegenerative disorders is crucial. Sometimes medications like melatonin or clonazepam are used to try and suppress the motor activity during REM.
It's just fascinating how interconnected sleep is with everything else.
It truly is, with our mood, our cognition, our physical health, even potential neurodegenerative conditions. It really underscores its foundational role.
Absolutely. Okay, just a couple more sleep-related ones. Restless leg syndrome, RLS. That uncomfortable leg sensation relieved by movement sounds incredibly disruptive to sleep.
It certainly is. People feel this irresistible urge to move their legs, often accompanied by creepy, crawly, or aching sensations. It's usually worse in the evening or at night.
What helps with that?
Medications like pramipexole and ropinirole, which affect dopamine, are commonly used. Regular exercise and things to improve circulation can also help. It seems linked to dopamine pathways.
Interesting. And finally, let's not forget substance-induced sleep disorder.
Right, where sleep is disrupted directly because of using or withdrawing from substances like alcohol, nicotine, caffeine, sedatives.
How does that disruption usually manifest?
Often it reduces the deeper stages of sleep, stage 3, and also REM sleep. So even if someone sleeps for a long time, the quality is poor, they don't feel rested.
Treatment there is obvious, maybe?
Well, the core is education about how these substances affect sleep and promoting healthy alternatives or moderating use. Addressing the substance use itself is key to normalizing sleep architecture.
Okay. We've just touched on how fundamental sleep is, and often, issues with sleep can be intertwined with other challenges, particularly when substances are involved.
Definitely a strong link there.
And that brings us perfectly to our final major category today, the specific nuances of different substance use disorders. Why tailoring the approach is so vital, looking at both intoxication and withdrawal.
Absolutely critical. Starting with probably the most common one, alcohol.
Right.
Intoxication signs are familiar slurred speech, impaired coordination, poor judgment, sometimes blackouts. But withdrawal, that can be really dangerous.
How so?
It can range from tremors and agitation to seizures, and in severe cases, delirium tremens DTs, which involves confusion, hallucinations, severe autonomic instability. It can be life-threatening.
So medical management is key for withdrawal.
Absolutely crucial. Medications like lorazepam or Clodiazepine, which are benzodiazepines, are used for tremors and agitation. Diazepam might be given intravenously for seizures. And thiamine, vitamin B1, is vital to prevent Wernicke's encephalopathy, a serious neurological disorder caused by deficiency.
And for longer-term management, preventing relapse.
Medications like acamprosate can help reduce cravings.
Yeah.
Disulfiram creates an aversion. If you drink alcohol while taking it, you get very sick.
Right, the antabuse effect.
Exactly. And then treatments include detox programs, rehab, 12-step programs like AA, CBT, motivational interviewing, a whole range of psychosocial supports.
Okay. Opioids next. Obviously a huge public health concern. What's the profile here?
Opioid intoxication typically presents with drowsiness, constricted or pinpoint pupils, slurred speech, maybe altered mood euphoria initially, but can shift to apathy. The big danger is respiratory depression.
Right. Breathing slows down or stops.
Exactly. Withdrawal, while generally not life-threatening like alcohol withdrawal can be, is intensely uncomfortable. Nausea, vomiting, muscle aches, yawning, runny nose, diarrhea, goosebumps. It's often described as like having the worst flu imaginable.
And the medications here are really important, especially for overdose and treatment.
Hugely important. Naloxone, or Narcan, is the opioid reversal agent for overdose. It's life-saving. For treatment, we have methadone, a long-acting opioid agonist that reduces withdrawal and cravings and blocks the euphoric effects of other opioids.
Okay.
Buprenorphine is a partial agonist, often combined with naloxone in formulations like Suboxone. It has less risk of misuse and respiratory depression than methadone. Clonidine can help manage some of the physical symptoms of withdrawal, like sweating and rapid heart rate. And naltrexone blocks opioid receptors entirely, used mainly for relapse prevention after detox.
So, medically assisted treatment, MET, is key.
MET is the gold standard for opioid use disorder, combining these medications with counseling and behavioral therapies. Other treatments include airway protection during overdose, detox, and rehab programs.
Okay. Stimulants, cocaine, amphetamines, a completely different set of challenges, right?
Correct.
High energy, euphoria.
Right. Intoxication brings that euphoria, increased energy, but also dangerous physical effects. Chest pain, heart rhythm problems, high blood pressure, seizures, paranoia.
And the crash, the withdrawal.
That's marked by the opposite. Severe depression, intense fatigue, lack of pleasure, vivid, unpleasant dreams, and sometimes a significant risk of suicidal thoughts or actions.
That's serious. Are there medications for stimulant withdrawal?
There aren't specific FDA-approved medications like there are for opioids or alcohol. Management is mostly supportive. Diazepam might be used for severe agitation or hyperactivity during intoxication. Antipsychotics might be needed for severe psychotic symptoms. And if someone develops significant depression after stopping stimulants, antidepressants like bupropion might be used.
Okay. What about hallucinogens? LSD, PCP, mushrooms. These sound like they'd have unique and potentially unpredictable effects.
Very unpredictable. Intoxication can involve vivid hallucinations, altered perceptions of reality, paranoia, anxiety. With PCP specifically, you can see agitation, aggression, and nystagmus, that rapid involuntary eye movement.
And withdrawal.
Formal withdrawal syndromes aren't typically seen like with opioids or alcohol, but users can experience distressing flashbacks, sometimes long after use, or persistent perception disturbances. For PCP intoxication specifically, benzodiazepines are used for agitation, and mechanical cooling might be needed for dangerous hyperthermia. For other hallucinogens, antipsychotics or benzodiazepines might help manage severe aggression or anxiety during a bad trip.
Okay. Cannabis. Widely discussed, increasingly legalized. What's the clinical picture for intoxication and withdrawal?
Cannabis intoxication typically involves red eyes, increased appetite, sometimes dry mouth, altered perception of time, maybe some euphoria or relaxation. In some people, especially with high doses or high-potency products, it can cause anxiety, paranoia, or even hallucinations.
And withdrawal. Is that a recognized thing?
Yes, cannabis withdrawal is recognized now. Symptoms can include irritability, anxiety, insomnia, decreased appetite, restlessness, sometimes abdominal pain or shakiness. Anxiety medications might be used short-term if needed during withdrawal, but mostly it's supportive care.
Right. And tobacco. We know withdrawal is tough.
Very tough for many people. Withdrawal typically causes irritability, anxiety, difficulty concentrating, increased appetite, restlessness, insomnia, and intense cravings.
Medications can help.
Yes. Bupropion, the antidepressant, is also approved for smoking cessation. It helps reduce cravings and withdrawal symptoms. And varenicline, or Chantix, works by mimicking nicotine's effects to some extent, making smoking less pleasurable and reducing withdrawal. Nicotine replacement therapy is also widely used, of course.
Okay. Lastly, let's touch on gambling disorder. Recognized as behavioral compulsion, right? Similar patterns to substance use disorders.
Very similar patterns, yes. It's a behavioral compulsion with significant negative economic and social consequences. It's not about a substance, but the brain pathways involved, particularly reward pathways, seem quite similar.
Are there medications used for gambling disorder?
It's interesting, some medications used for substance use disorders or mood disorders have shown some benefit. Bupropion, lithium, the anticonvulsant topiramate, some second-generation antipsychotics, and even naltrexone, the opioid blocker, have been studied or used off-label.
Naltrexone too.
Yeah, suggesting maybe some overlap in the reward pathways. Treatments also include Gamblers Anonymous, a 12-step program, various forms of psychotherapy, and CBT, adapted for gambling.
It really highlights how understanding the specifics is crucial.
Absolutely. If we connect this to the bigger picture, you can really see how understanding the unique physiology and psychology of each substance, and even behavioral compulsions like gambling, is crucial. Not just for effective treatment, but also for prevention, harm reduction strategies, and deploying critical interventions like naloxone appropriately.
So after covering all this ground, what does it all mean for you, the listener? We've journeyed through a vast breadth of knowledge in this deep dive. From the intricacies of impulse control and cognitive decline to the absolutely vital role of sleep and the specific, often difficult challenges of substance disorders.
I think it means gaining a more nuanced understanding of these complex conditions, recognizing patterns, maybe in yourself or others,
and appreciating the diverse, often very tailored approaches needed for treatment and support. Rarely one size fits all.
Definitely not. And, this raises an important question, I think. How does recognizing these distinct yet often interconnected aspects of mental and neurological health empower us?
How does it empower us?
Well, empower us to better understand human behavior, perhaps, and to support not just ourselves, but maybe those around us more effectively in a world just saturated with information and sometimes misinformation.
Yeah.
It really highlights, I think, the profound impact that understanding these disorders can have on fostering empathy and delivering truly effective care and support.
That's a great point. Understanding fosters empathy.
Yeah.
Absolutely. We really encourage you to continue your own deep dives, keep exploring these fascinating, important topics. There's always more to learn about the intricate workings of the human mind and brain.